Reform. We all talk about reform. There's almost a consensus emerging among candidates that something called access through universal coverage is important. But surely we need to drill deeper. You've and Michael wrote about reform, and you certainly wrote about access. But you also wrote a lot about value. And I guess I'd like you to maybe kick this off a little bit, talking about this access discussion, but where it needs to go as part of this whole campaign political process.
Okay. So I'm going to put it in a frame, and I'll come to access in just a second, but when I started talking with people about healthcare, about redefining healthcare, I started with the statement that the healthcare system should be about health and care. And somebody who you would all recognize, so I won't name him, raised his hand and said, "Dr. Teisberg, that's too radical." I beg to differ. It's not too radical. It's where it has to be. The goal of healthcare is not cost reduction. And actually, when we act as if it is, we inadvertently drive costs up. If the goal were cost reduction, then painkillers and compassion would be all we'd need, right? The goal is to improve value in healthcare. And by value, I mean that health outcomes for the money spent. We need a system that drives improvement in value. When patients experience value when their medical circumstances, their combination of medical circumstances, are treated effectively and efficiently. Okay? So that's what we need to drive improvement in. So let me make 3 observations. The first about access. Our research led to the inescapable conclusion that the system has to include everyone. And I'll give you 2 main reasons for that. The first is that the cost shifting won't stop as long as some are in and some are out. And we spend and waste a tremendous amount of effort and money on those cost shifting battles. Right? So if we want to stop some of those ridiculous games, we have to have everybody in the system. And the second reason is it's efficient. So not just for equity, but also for efficiency. And let me point this out to you in 2 ways so you can see what I mean. The first is that when you have everybody in the system, people have access to early stage and primary preventive care. And that's more effective and less expensive than waiting until late-stage acute problems occur and trying to handle them in expensive settings where we're less effective in actually dealing with their medical circumstances anyway. It's strange to me that we fail to notice that in Europe, in the systems where everybody's in the system, it's less expensive. This isn't a knife-edge result. It's true in all the systems. It doesn't matter whether the physicians are employed by the government or the physicians are privately employed. It doesn't matter whether you have multiple payers or a single payer. Both exist in European systems in different countries. Multiple payers, single payer. It doesn't matter whether the government provides the insurance or whether there's a mandate for individuals to have to buy insurance. In all of the systems where there's universal access to early stage and preventive care, it's less expensive than it is in our system where we spend so much money trying to figure out who we're keeping out when. Okay, so it's efficient. And then the next observation is that if all we do is get everybody in the system, it won't work. Mark's right. Right? The system will topple under its own weight if we put everybody into the current system and don't make other changes. We need to redefine the way we think about and deliver health care. And that is radical, but it's critical. We need a patient-centric approach. Notice I didn't say consumer-driven, but we need a patient-centric approach that is results-driven. We need to drive improvements in results. And that means thinking about things from the perspective of what Mike and I call medical conditions, meaning a combination of medical circumstances as the patient experiences them. So you need to think about systems designed to improve results over the full cycle of care for medical conditions as patients experience them. And that means a reorganization of care delivery, and I can give you examples of places where that's going on, but a reorganization of care delivery, it means a reorganization of how even the health plans and the suppliers think about their products and their services in order to drive improvements in results for patients. And the third observation then is that if we want to drive improvements in results for patients, we need to measure them. We need to measure outcomes. Risk-adjusted, peer-reviewed, well-vetted measurement, sure, but they won't be perfect when we start, and that's okay. But we need to measure results because clinical teams need to know what needs improving and when they're improving it. And when we actually measure results, we get improvement. One short story to illustrate that, then I'll turn it back for you. Think about cystic fibrosis. Complicated. This isn't surgery where people say, oh yeah, that's relatively easy. He knows how to measure outcomes, but the rest of us don't. Think about cystic fibrosis for a moment. Years ago, there was a doctor at Rainbow Baby and Children's Hospital reporting lifespans for his patients twice that everybody knew was possible. And a study was funded essentially to disprove his results and stop him from making these unreasonable claims. What the study showed was that throughout the country, there was an incredible variation in results, and his were spectacularly good. And over time, as the clinical teams began discussing what drove those differences in results and why it was that some were getting better results than others, the average lifespan for a patient with cystic fibrosis went from 18 years to 33 years. And stay with me. Those achieving lifespans in the 30s before that went to 47 because the process of sharing insight and thinking about what was really driving improvement drove not only the bottom to come up, but drove the best to improve even more. We need to measure results. It's a win-win. When you think about improving value, it's a win-win situation, right? The patient wins, the clinical team wins, the health plans win because good health is less expensive than poor health. Remember, the good here isn't treatment. The good is health, right? And good health is less expensive than poor health. So we shouldn't fool ourselves. The goals are health and care.
I want to pull.
My question is, how do you shift power? Because today, the manufacturers of drugs or devices, and those are really the companies that have the power. They have the lobbying power. And they really, I think, put up barriers to a lot of the reform efforts that need to take place. Because if you look at it, the way that they profit is through the inefficiencies of the system. And if you make the system more efficient, it really squeezes their profits. And I'm just interested in how you get those companies on board. What are the incentives you need to provide to them in order to get them involved in being part of the solution and not being part of the problem? And I've always found it interesting as to, just the whole tobacco industry, how cigarettes, which we all know cause cancer, remain on the market today or as widely used when a drug like Vioxx that could be very beneficial gets pulled. I think it just speaks to the power that lobbyists have and this, shifting of power with corporations.
Let me start and then I'll pass it on. I'll just talk about the health insurance industry. I think it's interesting when I talk with colleagues across the industry what a variation you see amongst them. You have some who are still saying, problem? What problem? We're doing just fine. There are others who know there are problems, but I like to say they're like bull riders. They just want to stay on that bull for 8 seconds, and they're that close to retirement, and someone else will deal with it. And I've had people say that. Gee, Mark, I totally agree with that. We need to go there, but my successor will deal with it. And then you get people who begin to want to make change and are trying to feel their way there, but are still caught in kind of a control focus. I think the way that at least for the health insurance industry, that there's a possibility for change is that they need to recognize, or we all need to recognize, that the current model, we're dinosaurs.